series on gastroenteropancreatic neuroendocrine neoplasms. So today we land up with a third session and conclusive episode of metastatic GEP-NET, the evidence-based practice. So not taking much of time, I would invite Dr. Bhawna Sirohi, who is a consultant medical oncologist at Proton Cancer Center, Apollo, Chennai. And Madam is a lead medical oncologist working on GI and breast oncology. So welcome, ma'am, for the talk.
Thank you, Shefali, and thank you. It's a pleasure to see the whole MICC team on screen, and congratulations for organizing this. So I'm going to talk for 20 minutes on metastatic GEP neuroendocrine neoplasms. Basically, treatment options, even in metastatic setting, I am not going to cover surgery and liver-directed therapy, but these are also very important options in patients with gastroenteropancreatic neuroendocrine neoplasms. Watch and wait is a strategy that we should employ in some patients as well, and it's how we select the patients is very important. Somatostatin analogs, the targeted treatment, chemotherapy, PRRT, and telotristat is licensed for symptomatic neuroendocrine neoplasms, and it can be imported for severe symptom related like diarrhea. So it is, again, I will not go into the details because it's not easily available. So we have a long disease course for GEP-NENs, and it's important for us to know when to sequence treatment, which treatment to use first, so we do not compromise any future options. When not to treat and when to treat is also very important. The most important thing is that the MDT approach is crucial. There are a lot of guidelines, and in fact, we have the ICMR guidelines as well, which you can access, which were published in August last year. Observation, how do we select patients for observation? So I think this is a slide which really helps me. So as we look at the prognostic factors, so I used to run a neuroendocrine clinic in Cambridge, I remember, where we would have some patients who with me were on observation for years and years at 3-monthly intervals, where I would assess the tempo of progression in those patients with 3-monthly scans, and then we increase the interval of scans to 4-monthly and 6-monthly. So these are the prognostic factors: age, number of liver metastasis, Ki-67 more than 10% or less than 10%, and whether they've had the primary removed or not. So these can actually, it's all retrospective data, but it can help us in decision making. Sorry. So again, can't say it enough that if you look at having a multidisciplinary team which deals with the neuroendocrine neoplasms or tumors day in and out, the survival of patients is better. So if you look at the survival of patients treated at Moffitt Cancer Center, Uppsala and Berlin, it's much better than the SEER database, which had all the NET patients. And in Europe, I think we had this European GEP-NET centers of excellence, which were only allowed, which were the only centers which were allowed to treat neuroendocrine. Mainly, we know that the survival is 3 times higher for those patients who are treated in centers of excellence. What treatment is driven by pathology? Ki-67 is very important. The somatostatin expression, the tumor stage. Again, the somatostatin expression, the intensity and the homogeneity is important, the site of tumor. Very important right at the beginning, as we do with colorectal liver metastasis. We find out if the patient has liver-limited disease, because if we want to optimize the loco-regional treatment as well, the extent of liver treatment is very important, because I am not going to discuss the referral criteria for liver transplantation, but again, the extent of liver involvement will decide whether you would consider the patient for liver transplant as well. Performance status, patient choice, whether the patient has a functioning tumor, the availability of treatment is very important. And like I said, for me, in grade 1 tumors, Ki-67, or grade 2, less than 10% Ki-67, tempo of progression on serial scans is important. The evidence-based treatment, which I'll talk about in the next few slides, you have octreotide or the somatostatin analogs, the PROMID and the Clarinet study, Radiant story, sunitinib and the pazopanib, which was the Alliance trial, and capecitabine temozolomide. where you have randomized level 1 evidence that these treatments can be used in our patients. PROMID is a phase 3 randomized trial which randomized patients to octreotide LAR 30 milligram every 28 days and placebo. Um, Treatment was continued till progression. I think this is a very important point. Once you start your patient on this journey, you have to continue the treatments forever. So, and there is a huge cost implication involved for all of our patients in India. So, this trial showed that there is an anti-proliferative effect and it works in both non-functioning and functioning tumors with a prolongation in progression-free survival. If we look at the PROMID and the the Clarinet study used lanreotide and included GEP-NET patients. It had 45% patients had pancreatic tumors. PROMID mainly had midgut primaries. The Ki-67 is slightly different. The liver burden is again different. And the median progression-free survival, I just wanted to make this point that if you compare PROMID and Clarinet, the drugs have a pretty similar mode of action. The median time to tumor progression was 14 months versus 33 months in with lanreotide. So I'm quite often asked this question, whether lanreotide is a better drug than sandostatin, than octreotide. I don't think that is the case because the entry criteria, the eligibility criteria of the trials were different. And if you look at the median time from diagnosis to entry to the trial was about 4 months in PROMID versus 33 months in Clarinet. So patients with stable disease were also allowed to enter the Clarinet study. So I think the trial populations were completely different. So one cannot compare these. Subgroup analysis, because 45% had pancreatic tumor, shows that a somatostatin receptor analog probably has a better activity with a hazard ratio of 0.35. The curves are separating in midgut neuroendocrine tumors compared to pancreatic. The Swedish, briefly, I would like to say about interferon because we have a lot of patients who are some DOTA negative scans. So I find that interferon is a very good drug, especially pegylated interferon for these patients. This study randomized to sandostatin versus sandostatin interferon alpha, and there was a significantly better risk of tumor progression. I have used interferon in a couple of patients who were somatostatin negative on scans, and after giving interferon, it upregulates the somatostatin receptor. And this slide I've borrowed from Professor Kjell Åberg at Uppsala. So I think the somatostatin, the evidence is it is anti-proliferative. The hazard ratio for progression-free survival is similar for octreotide and lanreotide. So which patients would you select for this? For me, it would be low Ki-67, somatostatin receptor positive patients, slow growing midgut tumors mainly. And we know that it works both in functioning and non-functioning. The anti-proliferative effect is better in midgut neuroendocrine. Coming to the oral targeted drugs, the RADIANT program looked at the everolimus and neuroendocrine tumors. And as you can see that the median progression-free survival was significantly better with everolimus compared to placebo. 11 months versus 5 months with a hazard ratio which was 0.35, which is fantastic in this setting. Radiant 2, if you combine everolimus with octreotide versus octreotide and placebo, the hazard ratios were not, the progression-free survival was significantly better, but the hazard ratios were not so beneficial towards the combination. So if you look at the everolimus and sunitinib, both the studies came in the same edition of New England Journal of Medicine in 2011. And as you can see, the covers almost mirror each other. And we have survival data from sunitinib that it significantly prolongs overall survival by 25% in those compared to placebo. Pazopanib, this was presented at ASCO last year, the year before. And again, very similar progression-free survival of 11.6 versus 8.5 months. Between everolimus and sunitinib, which drug should we use? We know that everolimus, based on the data, may be more active in pancreas versus midgut. Because of paucity of time, I'll not go into the details. It's important to select patients with clinically significant progression. For me, I think the most important thing is consider starting lower doses in frail elderly patients. Cost is a huge issue because you have to continue these drugs till progression. If a patient has underlying lung disease or hypercholesterolemia or triglyceridemia, I tend to choose sunitinib. Otherwise, my preference is to go with everolimus. PRRT is something which I use quite frequently in my patients because cytoreduction is better, progression-free survival is better, and it is a one-off treatment that the patients can have. The NETTER trial randomized patients who had progressed on octreotide, randomized patients to lutetium dotatate versus control group who had a double dose of octreotide long-acting. And as you can see, the overall response rates were significantly better, and overall survival was also significantly longer in those patients who had had PRRT therapy. As far as chemotherapy is concerned, most of the data is retrospective, heterogeneous population. There is lack of standardized entry criteria, mainly single center and underpowered studies. I think the most promising data we have is with capecitabine temozolomide and platinum-based chemotherapy as well for grade 3 high Ki67 neuroendocrine neoplasms. I think this is something very important, that there's no role for chemotherapy if Ki67 is less than 2%. It actually has a counterproductive effect, so I would not use it unless as a last line option in a fit patient. The Uppsala data by Guido Rindi, I think they were the first ones to talk about a Ki67 cutoff 55%. And they showed that in the retrospective data set that patients who had a Ki67 less than 55%, they respond better to capecitabine temozolomide plus or minus bevacizumab or basically a capecitabine-based regimen, fluoropyrimidine-based regimen. So this study, again, was presented a few years ago, randomized to CAPTEM versus temozolomide. Primary endpoint was progression-free survival, and this is the only trial actually which shows that the combination had a progression-free survival of almost 23 months versus 14 months, and a significantly better response rate. The overall survival had not been reached. And we also have a biomarker actually to look at the response to temozolomide with the MGMT, the methylation status as well, because we know those who are MGMT negative, the overall response rates are almost 80 to 90%. So one can actually select these patients. I think the Spanish guidelines and the ICMR guidelines almost reflect this. I would suggest that I will not go into the details of these guidelines, but I would suggest that, for students, they should go through it. We have included for systemic treatment for where metastatic disease where R0 resection is not feasible for grade 1 and 2 GEP-NETs. Systemic treatment for pancreas Ki67 less than 10%, sunitinib. All of these are actually level 1A evidence. PRRT is 2B. But like I said, for all the systemic drugs, once we start, we have to continue till progression. You can't just give 3 cycles. So this decision has to be done with a lot of discussion with the patient. So I have included PRRT. So PRRT is something which is indicated by the ESMO guidelines up to Ki67 of 30%. And I think if you look at Sandeep Basu, some of his papers, at Tata Hospital, we have treated some patients with chemotherapy and PRRT with a Ki67 of up to 40% as well, because they had DOTA avid areas and FTG avid areas as well. So we have put in the ICMR and the Spanish guidelines as well, the grade 3 Ki67 less than 55%. This is the only point I wanted to make. Consider alternatives to platinum etoposide and consider fluoropyrimidine-based treatment. So, we tend to use capecitabine temozolomide as first line for even grade 3 neuroendocrine neoplasms with a Ki67 of less than 55%. So I think the old sequence has always been starting with somatostatin, then going on to everolimus for low intermediate grade. But I think for us, we have now started using PRRT before giving somatostatin. You can, of course, give somatostatin analogs with PRRT as well and give it before as well. And then this is the sequence, and then capecitabine temozolomide is last. liver-directed therapy can be used anywhere along this process. So I think it's very important to say that we have to work in a multidisciplinary setting. Consider the heterogeneity, because I tend to do both DOTA and a PET scan in most of my patients because it's a dynamic process over time. Low grade is defined by the key 67, less than 2% and maybe less than 6% in pancreatic neuroendocrine. The community is again talking about this. Very important to identify liver limited disease. PRRT is something which I favor over other options, and important to identify patients who don't need treatment. And I would suggest that you identify centers of excellence in your region. I have not discussed immunotherapy because the role of this is investigational. Thank you.
Yeah, thank you so much, ma'am, for a nice and crisp talk, well in time. So,
Sorry.
yeah, please unmute, ma'am. Yeah.
Sorry, thank you.
Yeah. So, Dr. Nikhil, you take over, please, from now.
So thank you, ma'am. Thank you for very nice presentation. There's one question from Moveen. What is meaning of heterogeneity?
So heterogeneity means in the same patient, you can have areas which are grade 1 and which are grade 2 or grade 3. So you would not go around biopsying each area. So that's why you would, I tend to do a DOTA scan and a PET scan in most of my patients. So the PET scan, the FDG avid areas would be grade 3 very likely. But FDG you may in the same patient have DOTA avid and FDG avid areas. So that's what I meant by heterogeneity.
Yeah, and the next question is, how will this change investigation and treatment?
So again, if the patient has both grade 3 and FDG avid areas, if you're planning PRRT in a grade 1 or 2 neuroendocrine patient, you would actually consider giving capecitabine or even capecitabine temozolomide with the PRRT.
But ma'am, would you like to biopsy both of the places, FDG avid areas as well as the DOTA avid areas?
If it is easily accessible, I think it is worth biopsying it, definitely. Yeah. In the same liver, we have done that. We've targeted an FDG negative and a positive area and found that the grades are different in the same patient.
Right.
I think that's very helpful for the students. Now I'd request Dr. Sandeep Batra.
I'm looking forward to the case discussion.
Yeah, hi, Nikhil.
Yeah. Please introduce your panel and then take it forward.
I hope the slide sharing has started. Thank you, Nikhil.
Yeah.
Okay, so thank you, Dr. Bhawna, for such a lucid and crisp presentation about the gastroenteropancreatic neuroendocrine tumors. I know time was short, so let's cover up the remaining things in the case, which is a clinical case, and it is always interesting to do a case discussion after the talk immediately, so as to improve the understanding amongst ourselves and for the students as well. So our esteemed panelists are Dr. Bhawna Sirohi. She has just delivered her lecture, a beautiful lady by heart, and now at Apollo Cancer Center, Chennai. Dr. Rajat Saha is a medical oncologist at Max Patpargan and Vaishali Complex. Dr. Peush Bajpai again is a medical oncologist at Dwarka, Manipal Hospital. Dr. Namita Sharma is again a medical oncologist, associate professor at ILBS Medical Oncology. Dr. Abhishek Aggarwal, I think, is a surgical onco, and he probably is not on the panel. Am I right, Nikhil?
Yeah.
Okay, so you will fill in the place for the surgeon.
I'll be happy to take that.
Okay. And Dr. Manoj Gupta is a nuclear physician, if I understand correctly, right?
Yeah.
Dr. Manoj, are you there?
Yes, sir, I'm here. Yeah.
Okay. If all of the panelists just briefly can say hi, we have heard Dr. Bhawna, Dr. Rajat, you are there?
Yeah, very much.
Dr. Peush?
Yeah, hi.
Dr. Namita?
Sandeep.
Dr. Namita?
She is not there, I think. I have not seen her name joining.
Okay. So I think still we have 5-6 people, and Dr. Shefali and Dr. Nikhil can pitch in as and when required and as and when forced by me. Okay. So let's start with the case. Now, this is regarding the gastroenteropancreatic. So I have taken a pancreatic case, a real life case, and there may be some individualization of the treatment involved in this case. But let's discuss what could be done versus what should be done in a clinical case scenario, because tumors have not read the books, we have read the books. So Mrs. LT is a 56 years female who presented to us in May 2018 with pain abdomen with a significant weight loss. An imaging done in the form of ultrasound had shown a pancreatic tail mass with liver SOLs. When she presented in our department, on examination, she had pallor, parabdominally, she had ascites, hepatomegaly with multiple omentoperitoneal nodules, but she was not jaundiced. She was performance status 1 to 2 otherwise. Biopsy was done after a CT scan, which showed it to be an intermediate grade neuroendocrine tumor, grade 2, with a Ki67 of 14 to 50%. CA 19.9 was 0.8, chromogranin A was 3198, and a DOTA PET after we got the NAT report showed a hypotense lesion 1.5 into 1.4 centimeter in tail of pancreas with hepatomegaly with multiple DOTA avid hypotense liver lesions, largest of 7 into 5.8 centimeter in segment 8. There were DOTA avid retroperitoneal lymph nodes, largest of 1.5 into 1.4 centimeter. In the gastrohepatic region, there were no other DOTA avid lesion in the rest of the body surveyed. And this is the imaging at the presentation. So you can see there is a mass in the pancreatic tail, plus there are multiple lymph nodes, retroperitoneal, and multiple liver lesions. So let's start with Dr. Peush. So Dr. Peush, if this type of patient presents to you in 2020, so this was 2018, 2020, it's a PS.
वॉल्यूम कम करो, आपको डिस्टरबेंस होगी तो मुझे कोई डिस्टरबेंस नहीं, मैं हेडफोन लगा सकता हूँ ना ना कोई दिक्कत करना पड़ेगा
ओके हेडफोन लगा लो दोस्त बट कंटिन्यू करो पॉज करके अपने आप को सो डॉक्टर पीयूष if this patient would present to you now based on your current updated information and the lecture we had just from Dr. Bhawna, what will be your choice of treatment offered to this patient? Patient is PS1 anemic, not jaundiced, with a hepatomegaly, with the liver studded with the disease, with the suspected pancreatic primary, and with the multiple retroperitoneal lymph nodes. It's an abdominal confined liver metastatic disease.
So I would consider starting somatostatin analog over here. Octreotide LAR would be my choice of treatment to start with. However, as Dr. Bhawna suggested, and we have just started doing PET-CT in grade 2 and 3 NETs. So that is one thing that can be considered in addition to the investigations we have done.
Okay, suppose if it shows FTG avid lesions, which are not as DOTA avid and slightly at a different places than the DOTA avid lesions, would you add anything to somatostatin analogs in the treatment of this patient?
Well, for now, no. I would not add anything beyond that. I'm not using interferon. I haven't used interferon personally. This is not a this tumor. This is a functional tumor. Did you mention?
No, it's not a functional tumor. It doesn't have any function.
I have not used any interferon so far, but probably, as Dr. Bhawna said, and taking from her experience, probably we can consider, but I have personally not used it. Non-functional NETs, we have data from the PROMED as well that it has anti-proliferative activity. So hopefully I would depend on that. It might lead to increased dose. We might require an increasing of dose, or probably frequency of it might be increased if in case we do not get the desired responses in chromogranin A.
Okay. So if I understand correctly, so you will give single agent SSTR inhibitors, and if the dose, the response is not as per your expectation, you would like to increase the dose.
That would be the first step for change.
Okay.
PRRT, since you said that there are FDG avid lesions, so PRRT takes a backseat.
No, so that was a hypothetical consideration. Okay, let's stick to this case. This is the DOTA findings. We had not done the PET scan, considering it's an intermediate grade 2. So we had not done a PET scan at that point of time in 2018. Suppose 2020 also, there was no FTG avid lesion. will you consider PRRT, as Dr. Bhavna showed in the flow chart, that probably people are shifting to upfront PRRT in such patients?
I think so. PRRT is coming up in the algorithm, but for now, I have been practicing probably because what I'm telling you is what I am practicing as of now.
Okay.
It would be octreotide LAR. However, yes, PRRT is definitely climbing up the algorithm.
So, Dr. Rajat, have you any difference of opinion regarding the use of SSTR versus use of any other agent plus minus the SSTR inhibitors?
This patient has a high burden of disease and a symptomatic high burden of disease.
Yes.
So in this patient, from our experience, octreotide LAR, I would be more comfortable in using in a patient with a comparatively asymptomatic patient with whatever burden of disease. This is a high burden disease with significant symptoms. I would be more inclined towards using PRRT because it's a highly DOTA-avid lesions. I would be using PRRT as the first line of treatment for this patient.
Okay. What if it was 2018 when you did not have sufficient data for PRRT in the upfront setting?
Then I would have used probably maybe octreotide, yes. Maybe potentiated it with adding everolimus also.
But Rajat, is there any data to use upfront everolimus?
No, it is not there.
It's not there.
We can start with octreotide LAR, and at the first hint of progression, then I would add everolimus.
Okay. Any idea about using something like CAPTEM or any other cytotoxic chemotherapy?
CAPTEM, yes. Now, one important thing which was highlighted was the MGMT methylation status. We can just check it by if it is MGMT methylated, then yes, it can also be one of the. But I have not used it as a first line treatment option.
Not used as a first line. So, so you partly agree with Dr. Peush that SSTR inhibitor, that is octreotide, but you have something at the back of mind considering the quantum of disease, volume of disease. You want to add on something so as to improve the results because you may not get a second chance to treat this patient if the disease progresses. Dr. Manoj.
Yeah.
If your oncologist would have sent this patient to you for upfront PRRT in 2018,
yes,
would you have given PRRT to this patient?
I think definitely, sir, because see, if you at the Dr. Rajat has said, the patient has a high volume of disease, and definitely, and even in the 2018, I should have done a FDG scan into this to rule out any FDG positive lesion.
It was not FDG avid.
All right. So if there's no FDG avid lesions with such volume of disease, then probably a combination of PRT with LAR, both has to be used together.
So for the understanding of the postgraduates, there is still a theoretical risk of not using octreotide LAR or short-acting octreotide along with the DOTA-PET therapy. Even if we use it as on today, there is some gap which is required 4 to 6 weeks prior to the PRRT therapy, and you can restart about 24 hours after the PRRT therapy, if I understand correctly. But do you think you had sufficient data in 2018 to advise PRRT in the first line? May 2020?
In 2020, definitely we have the.
Yes, we have, but in 2018, we're talking 2018.
2018, obviously the trial was on. So it was not FDA approved, but the trial was on because that NETRUS trial was started in 2012 and it was finished in 2015. So the data was, started to coming. So though there was no publication at that time, but, no phase 3 trial, but phase 2 trial definitely was available. I think is a matter of, taking the individualization of the patient.
Conviction and the individualization. Conviction in the data and the individualization. Dr. Bhavna, we come back to you. Your opinion, how would you have treated in this patient in May 2018?
So I would we were using upfront PRRT. I remember in Tata in 2013 also, because that was a very good option for our patients who could not afford all of these drugs, which are all very expensive. Even the generic octreotide is quite expensive. and PRRT could be done in 15,000 rupees, one dose. So here I think very good options are octreotide, then the SWOG trial with, if you want a rapid response, the progression-free survival was 16 months with bevacizumab and octreotide. And of course interferon and octreotide, but you have more side effects with that. My first option would be, depending on resources, PRRT is also, if you want a rapid response, is a very good option first line.
What is the response rate to PRRT in the upfront setting?
60 to 70%.
60 to 70%. Okay. So I think we had out of the two favoring PRRT, two favoring somatostatin analog, and one favored addition of something to somatostatin analog receptor blockers to improve the outcomes and to give the opportunity, second opportunity to treat. So we have already discussed this. Somatostatin receptor inhibitors, chemotherapy. If chemotherapy, then probably capecitabine plus temozolomide versus addition of interferon versus one view was everolimus. But all these options are there. And obviously, the discussion this case has generated was also generated in 2018.
Dr. Sandeep
yes.
and Dr. Bhawna ma'am, just to clarify one of my doubts, I thought PRRT definitely has a role in pancreatic NET, but relatively more in GI NET. So is it that the response rates in pancreatic NET, what my impression was, were relatively not so robust? That's what I felt as a general impression.
It's a small study, and if you have a DOTA avid with a key 67 less than 30%, FDG negative. So again, all these trials are all small, and we are learning from each other, from everywhere. So I still take a lot of opinions from my colleagues in India and abroad, because there's no right or wrong answer. Where a patient is resource limited and you have the option of PRRT, which is quite cost effective, I would say, then rather than going with something which they have to fork out 20,000 rupees a month, go with one-off option. That's what we did in 2013.
So I think here comes the rules of the MDT when you sit along with your nuclear physicians and the surgeons, medical and the radiation oncology colleague to find out what is the best outcome for the patient, what is going to be the best treatment and outcome. Absolutely. And the same discussion was done in our MDT as well. So this is the real note which I have picked up. So the same thing that was at the back of Rajat's mind, we share the same birthday otherwise. So the same apprehension was on the back of my mind. So I discussed with the family, and after discussion with the peer group, in view of the quantum of disease, the necrosis, the significant type B symptoms, I thought to add chemotherapy to the octreotide LAR, because I thought if the patient would have progressed, then probably we would have not a second chance to treat this patient. So this patient, now it's called individualization, and even all the literature and NCC also say that not every patient is unique and you have to individualize. You can see this is from NCC in 2020. Alternative frontline therapy in the upfront setting with a clinically significant tumor burden is again an option beside octreotide or lenalidomide. Okay, so this patient was started on chemotherapy. Now, one would have questioned what was the chemotherapy given. So I had not used CAPTAM in the first line. So I am a big fan of etosis, even though it was an intermediate grade. But on the background of SSTR inhibitor, I was courageous enough to start with the topocyte cisplatin, and to my belief as well as the patient's respite, patient had a partial response after 3 cycles. Chromogranin A, which was more than 3,000, reduced to 1290. And after establishing a PR, she was continued on 3 more cycles to complete 6th cycle. And after 6 cycles, she had a stable disease with a very good quality of life, and chromogranin reduced to 928. Now, this is almost about September 2018. 6 months of treatment completed, 6 cycles of treatment completed. Now, what are the options? Giving some maintenance treatment beside octreotide LAR, or anything that we can intervene? We come back to you, Dr. Peush. Having established a PR and then a stable disease with chemotherapy, with the background of SSTR inhibitor, octreotide LAR, what would be your choice now?
I think so. A continuation of octreotide right now would be there.
Till
That
progression.
is, yes, till progression. I would like to continue and see the tempo of disease. Yes.
So Dr. Rajat, do you agree?
Yeah. We continue with octreotide LAR.
Dr. Manoj, do you think we should have given the benefit of PRRT at this point of time after establishing a stable disease?
I think so. No.
No.
Because if the disease is stable, then we can continue with the somatostatin analogs only.
Okay. So Dr. Bhawna, you agree with the maintenance somatostatin receptor inhibitor?
Yeah, I do.
Okay. Let's see what we did in this patient. So everyone is in favor of continuation of octreotide LAR. So she was continued on octreotide LAR. In almost after about 2-3 months, she presented with minor symptomatology, and PET scan had showed most of the liver lesions and abdominal lymph nodes had increased in size and total cavity, and pancreatic lesion has also increased in size. Mild increase in the serum chromogranin from 900 something to 1010. Now next what? Chemotherapy again. Obviously, you would like to continue octreotide, sunitinib, everolimus, PRRT, CAPTEM. We have data for everything, but we have to give one option to this patient. So Piyush.
Yeah, so at this point, I would consider doing a PET along with Dotanoc. And if I am now looking at the option of PRRT right now to position PRRT, PET would be required. Dotanoc is already there. If PET-avid lesions are picking up, then PRRT is not my option. I would rather choose everolimus. The TKIs would be my first choice.
Everolimus or TKI?
But is it like the burden of disease has come down than the baseline, right?
Yes.
That was lesser.
Yes,
than
it has come down.
So everolimus would be my
everolimus.
Next, yes.
Dr. Rajat?
I would go for PRRT therapy at this point of time.
After doing FDG PET, if it is not FDG avid, then you will go for a PRRT therapy.
Yes.
Dr. Shefali?
Yes.
What, PRRT therapy or everolimus or sunitinib?
So, I mean, first of all, I would like to make a comment here. Grade 2, I am fond of using CAPTEM also. So, few of my patients are on frontline CAPTEM. They are doing well. And now, if the choice, I mean, I have to choose because the patient is on SSTRI. So, after doing a Dotanoc and a FDG PET, I would like to add on everolimus to this SSTR inhibitors and go on. If there is not much a burden of increase there.
No, just for the sake of clarity for the postgraduates, would you like CAPTEM in the second line or you would like to add everolimus in this patient?
This patient, I would like to add on everolimus, but I was mentioning that I'm fond of doing CAPTEM in the first line, even in grade 2.
Okay, first line. Dr. Bhawna?
So I would go for PRRT.
You would go for PRRT. In 2018, right? Not in 2020, 2018.
Yeah.
Okay.
Because all of these are good options, and also feel most of our patients need everything.
Okay, so we have a 50-50 divided house, 2 in favor of adding something to the octreotide and 2 in favor of the PRRT. Dr. Manoj, so I think if you say yes, then probably balance is going to tilt in the PRRT.
Yes.
You are the kingmaker now.
Yes. So I'm in favor of PRT definitely, but need to show that there is no FDG avid lesions.
So, okay, so we have the case scenario, FDG avid, then probably no PRRT, but a second line everolimus or CAPTEM. And if it is FDG negative and it is still expressing SSTR inhibitors, then she is a good candidate for PRRT therapy. Let's see what we did in this case. Oh. So we started her on everolimus 10 milligram. We know everolimus is a very, very toxic and tricky drug. So she required admission for supportive cares because of the everolimus induced toxicities, and the dose was reduced. I think most of you would concur that decreasing the dose to 5 mg also can give the same benefit if the toxicity is controlled. And after 5 months of starting everolimus, she was maintaining weight and appetite, and chromogranin A had partly reduced from 1010 to 926. And a PET scan, DOTA PET scan showed that in contrast to what was there clinically as well as the chromogranin A wise, the most of the liver lesions had increase in size with increase in necrosis and decrease in dotanocavidity. The portal vein thrombosis had mildly increased in dotanocavidity. So Dr. Bhawna, how do you interpret this DOTA-PET in light with the clinical symptoms which were reduced, weight and appetite maintained, quality of life maintained, chromogranin A stable? Do you think that everolimus is working, it is stabilizing the disease, or it is a disease progression?
I think it's working if we go by the CHOI criteria.
Okay.
So I would actually do a response assessment based on the CHOI criteria, especially as there is necrosis.
Okay.
And
so
look at the density of lesions, yeah.
Okay, so you if it is a responding disease, you will be in favor of continuation of everolimus, or you would like to change the therapy now?
I would be in favor of continuing at
Okay,
the review close.
Dr. Peush,
Yeah,
your
I
interpretation
agree.
of this PET scan finding along with the clinical attributes of the patient and choice of treatment.
No, so with the increase in necrosis, I think so what is important, we need to look at these tumors with a functional scan in the background of a functional scan. So I think so our treatment is working. Currently, we should continue it.
Continue. Dr. Rajat, do you agree?
Yeah. Let us continue with everolimus.
Dr. Manoj, it is
Yeah,
still
I think
DOTA-AVID.
Yeah. But if you see the report is showing decrease in dotanocavidity, so which is a clear evidence that there's an increase in necrosis, decrease in dotanocavidity, and patient is stable or asymptomatic kind of thing. So I think the drug is working. Yeah.
Okay. So the patient was labeled as a stable disease. She was continued on everolimus. In September, that is almost about 1 year after everolimus, the scan was suggestive of a characteristic progressive disease. Now we are limited by choices. We have already used one line of chemotherapy. We have used everolimus. We are still having PRRT and sunitinib as a clear choice, and CAPE and TEM is one of the options provided patient is eligible for that. So Dr. Bhawna, now after the chemotherapy and the everolimus, I think your choice will be again PRRT, if I have guessed it correctly.
Yeah. Or even CAPE-TEM. CAPE-TEM is a good option, especially if the FDG is negative, and that means the patient still has a Ki67, likely less than 55%.
Okay, so since we are into the neuroendocrine webisode, so I will make it a blank statement that FDG is negative in this patient throughout. So it's a somatostatin expressing tumor. So you now think that PRRT therapy versus CAPE-TEM both are good options. What about sunitinib?
So the patient is already progressed on a TKI with sunitinib. There is no data on using one after the other, but I mean in clinical practice,
that's an mTOR inhibitor. Everolimus is, yeah, no doubt there is no data after the mTOR inhibitor, but practically TKI is one of the options we have not used. Everolimus is mTOR inhibitor, so there is no cross reaction between them. So PRRT versus CAPE-TEM. Peush.
Yeah, I think so. CAPE-TEM can be considered PRRT because the avidity was coming down, so I would consider CAPE-TEM right now. PRRT I would like to use earlier in the second line post failure of octreotide. There only I would like to consider PRRT straight away.
So right now the avidity has increased. That was on the everolimus that it has gone down. After about 1 year, it has again increased. So the patient is still a candidate for PRRT if we go by that.
Yes, then PRRT can be considered.
Okay, so both the options divided. Rajat?
So I would personally like to go for PRRT therapy, but whenever I discuss this type of case with my colleagues, the question comes up with PRRT therapies is if you are using PRRT therapy, then down the line the bone marrow suppression will be there and you will not be able to use CAPE-TEM. So that is a common argument which is given in.
So I am one of those colleagues, Rajat, if I am correct. So even I have that issue in my mind.
So I am a proponent of using PRRT therapy earlier on in the disease rather than later on. So let us argue on this point. Where do we position ourselves?
Okay, Shefali, your input. CAPE-TEM is still remaining. You have not used it versus PRRT therapy. Sunitinib, no one has favored after the failure of everolimus.
So one thing more I would consider in deciding is if it is a significant increase in DOTA avidity, so and not a much burden of disease that much, and liver limited or one or two new progressions in bone, of course, PRRT would be my choice. Otherwise, considering mild increase in DOTA avidity and increase in tumor burden too much, I would go for a CAPTEM based treatment. So though no evidences to suggest anything like so a patient's experience and all these things matter. I think.
I think it would be needless to ask Manoj. PRRT, there are already 3 proponents. So let's see what we did in this. Manoj, still a PRRT candidate, right?
Right, sir. Yeah.
Okay. Okay, so patient was advised PRRT therapy. However, due to logistics and permissions, as a stopgap arrangement started on Cape Time. So patient had best of both the opinions. Got the advice of PRRT, but since patient was a panel patient, there was some procedural delay in getting the permissions. And to fill in the gap, we started with the Cape Time. Post 2 cycles of Cape Time, she had symptomatic improvement. Post 3 cycles, there was a mixed response with decrease in liver lesions and portal vein filling defect, but there was increase in the mediastinal gastrohepatic and mediastinal lymph nodes. So it was a mixed sort of response with a, though the clinically symptomatology was improved, chromogranin was running to the higher side from 900 something to 1941. So as we had planned for a PRRT therapy in this patient, so this is the typical picture in 2019 after progression on after the treatment of Cape Time 3 cycles. Since the patient was clinically well and there was a mixed type of response and we still not had got the PRRT permission, we continued the patient on Cape Time. However, she did not tolerate cycle 5 well, required repeated admissions for supportive care, and chromogranin A rose further to 3403. And a CT scan done 1 month after the last PET scan showed the liver lesions and nodes were unchanged. Pancreatic lesion was unchanged. However, there was mild ascites, which has come up as a nuke symptoms, and patient was having toxicities. Now we are left with sunitinib by PRRT. PRRT procedural delays, but ultimately patient got permission for PRRT and was started on 3rd of February. Patient was asymptomatic till May 2020. So Dr. Manoj, here we would like to ask from you for the benefit of our postgraduates, what is the standard schedule for PRRT? How many sessions, how many months apart? What are the key precautions you take while the patient is on PRRT?
Sir, if you ask me the schedule, it's given normally at a 8 weeks interval.
Okay,
And
how many times?
Yeah, 4 cycles are generally the standard one, but the 4 is not the limit. It can be given beyond 4 as well, but generally we prefer to give 4 at an interval of 8 weeks.
Interval of 8 weeks. And
Yeah.
is there any specific precaution while giving PRRT, something like renoprotective drugs or radiation protective drugs you give?
Sir, we don't use any radiation protective drugs. We definitely use renal protective fluids. So it's basically a basic amino acid what we use in our patients. So that is a basically aminoven 10% we use, which we started start around 30 minutes before the infusion. So that will reduce the toxicity to the kidney.
Okay. So kidney toxicity is a real issue with PRRT. So for the benefit
Sir,
of the post, yes, please.
yeah. See, whatever the literature is available as such, there's no grade 3 or grade 4 renal toxicity has been reported, but to reduce it further so that there's no long-term, toxicity. So that's why this amino acid being used along with PRT.
Okay. So what about that issue that Rajat and I assume we don't have evidence for that about the bone marrow toxicity with the PRRT?
Sir, we have used, I think, quite a few number of patients for PRT. Even if you see the NETAS trial, the data of the safety, it shows that the grade 3, grade 4 toxicity is less than 10%. Mm-hmm. Okay, so that there's not a huge amount of even anemia or thrombocytopenia which has been reported. So I feel if the patient to begin with at the baseline, if he has a good amount of hemoglobin or TLC count, then the chances of toxicity is very, very less.
Okay. So continuing with this patient, and COVID changed everything. So after the first PRRT, Subsequently, second, third were not delivered at time because of the permission issues, as well as the lockdown, as well as the accessibility to the care. And patient developed symptoms in June 2020. She had only one course in March 2020. Chromogranin increase almost doubled, and patient became symptomatic again. So she was started on sunitinib as stopgap. However, within days of starting with the sunitinib, she presented with hematemesis and melena. So as a out-of-box thinking with as an anti-proliferative drug without any data, intolerance of sunitinib, non-availability of PRRT, not physically fit for any other treatment, we started with thalidomide for whatever benefit as an anti-proliferative orphan drug that can give. And in September 2020, she presented with the disease progression, increase in the mediastinal lymph node size, some decrease in the duodenal cavity of the liver lesions. However, the iliac bone, the new bone lesions had come out, which had increased. Now she gets further approval for the DOTA therapy. So Dr. Manoj, we come back to you. Only one session in May, now in September, October 2020. Are we ready to give second session? Should we say it was because of the lack of PRRT that patient progressed, or it is no response that patient has got that we should discontinue? Manoj.
Can you just repeat, because there's some internet issue here?
Okay, so I would say patient had a first course of DOTA PRRT in March 2020. She had symptoms in May, and in September when we did the scan, when the systems opened up, when the approvals were again there, she had a progressive disease. However, she had in her hand approval for second course of DOTA therapy. Should we label it as a disease progression and discontinue DOTA, or should we label it in the absence of DOTA therapy, the disease progressed and we should go ahead with the second, third and fourth course?
So did we have any, FDG PET scan in this patient before starting the PRT?
Before PRT, it was negative.
It was negative because, sir, my experience, like after 3 lines of treatment, the chances of PRT effect will be definitely less.
Yes.
Okay, so we need to see how much the disease has progressed. So if the disease volume has increased, then we have to take it as a progression disease, and then how much is the avidity is left. Okay, so the both thing need to consider.
Okay. So there were new lesions coming up on the PET scan.
Yeah,
old lesions had some decrease in the DOTA avidity, but there were new lesions which were DOTA avid.
So if there are more lesions which are coming, then I think definitely disease is progressing, and which we expect as well, because after so much of line of treatment, then chances of de-differentiation or chances of higher grade of neuroendocrine tumors are more likely.
Okay, so Dr. Peush, at this point of time, you would consider any sort of chemotherapy in this patient?
Peush, I think so, left. He gave a message.
Okay, Rajat, then we come to you. Yeah. Patient is PS2, post multiple lines of therapy, Cape-Tam, sunitinib, everolimus, PRRT also one course, and we think that it is a disease progression. We don't have anything else in hand.
So I think so we should give the PRRT therapy another chance, because we don't have any other systemic therapy to offer.
So it's almost 6 months that we had only one course. We really don't know what has worked, what has not. Dr. Bhawna, do you think that we should go for a second course in this patient? Because we are not left with choices.
I would, and I was just going to comment. I mean, I've had some patients who had like 12 to 16 sessions of PRRT.
Yeah.
And especially
in a responding disease.
Germany. Okay, and I'm just seeing a patient who's had 17 sessions of PRRT. He's currently in Berlin, and marrow has not been an issue at all. And I would definitely consider, if her performance status is good and her organ function allows, I would consider DOTA. I would consider PRRT, yes.
Okay, so I think we agree that if we were spoiled with choices, then probably we would have shifted to other things. But still, as in this case, we have utilized majority of the things, rather most of the things. PRRT attempt should be done because there is a 6-month gap between the first course and the next plan. So she received second DOTA therapy on 7th October, and December 2020 it showed a further increase progressive disease with the new effusions coming up. However, the effusion is negative for malignant cells, but the disease is she's pretty symptomatic from disease with the loss of weight and appetite. So outline of the treatment is pancreatic neuroendocrine tumor grade 2 metastatic at presentation March 2018. and almost 3 years from diagnosis. Platinum-based chemotherapy with octreotide, PR after 3 cycles, stable disease after 6, progressive disease after 9 months, everolimus for 8 to 9 months, progression, CAPE-TAM 5 cycles, progression, then PRRT first session, then sunitinib, did not tolerate, thalidomide, progression, PRRT, second session, 2 months later, progression. So I think we have given maximum to this patient. We are still left with something like FOLFIRI, FOLFOX, which I think when the disease is progressed on capecitabine and provided patient's performance status is not good, will not be an option. As immunotherapy was discussed for very brief, I will not discuss that because we don't have much data for the immunotherapy in this patient. But I think since there is a blanket approval for the MSI high tumor, this patient has been advised MSI high so as to see whether there is a possibility of immunotherapy or not. I think with this, I will thank. Yes.
Means this is a question to our nuclear physicist, means Dr. Manoj. Do we have any specific advantage of actinium PRRT therapy vis-a-vis the lutetium PRRT therapy, which we are routinely giving? Actinium is the new radio.
Yeah, the actinium 225, which is basically a difference between lutetium and actinium, that the lutetium is a beta emitter and the actinium is a alpha emitter. So alpha is basically a high energy, nuclide. But so far the data is very limited. And there's no much data is available for the actinium. So truly speaking, head-to-head comparison is not available. So I'm difficult to say that which drug is better. The data is available for the lutetium, so that's why it's being preferred.
Okay, so I think lutetium is easily available and being used widely. So for the benefit of the postgraduates, so here comes the clinical scenario where we should choose wisely. Patient should receive benefit of each and every treatment which is available, and we should see what the patient can tolerate and what is logically possible, financially viable. And with this, I will thank all of my panelists, esteemed panelists, for their active participation. I see a lot of questions being there in the chat box. If Dr. Nikhil can help us in asking these questions to the relevant experts. Thank you, everyone. Thank you.
Thank you.
Thank you, Dr. Batra. So most of the questions actually got answered in the course of the discussion. And there was one question which Bhawna ma'am answered in the chat box. So I will ask some questions. Ma'am, you mentioned CHOI criteria. So can you just elaborate on that?
So I think it looks at the size and the density of the lesions. It was basically designed for, when we started using bevacizumab years ago. And what we were seeing that in liver, the lesions would just liquefy and then the size of the lesion would increase. And basically we realized that it's actually not progression, but a very good response. It's just the tumor had just necrosed and the wall had become bigger. So I think that came from bevacizumab response assessment. So not RECIST, but so I think for all of these, we have immune-related RECIST, we have CHOI criteria for drugs like targeted treatments, basically, and TKIs, which they can look at the density and calculate, the radiologist.
Right. So, ma'am, one question more. So, is there any concept of giving neoadjuvant type of treatment in metastatic GEP-NET, who is, that when the tumor is initially unresectable and using the CHOI criteria to define the resectability at later point time? So, have you, in your experience, is there anything like that also concept-wise?
So I think there are some papers and case studies. I have used it with Dr. Shikhande and Dr. Sandeep Basu in a few patients to downstage patients to get them to resection, especially some pancreatic neuroendocrine.
What did you use to downstage them?
PRRT along with chemotherapy, and we used capecitabine as a radiosensitizer. So not in chemo doses, but like we use for radiation with the rectal cancer, that type of doses we used with PRRT.
And what was the kind of response rate, ma'am, did you get? I mean, in terms of conversion to resection?
I think Sandeep is publishing that. I think there are about 5 patients they've used it. And I don't know exactly what the downstaging was, but I remember using it in a couple of patients where the surgeon felt that if we downstage, they could get the patient to resection. So then, rapid response would be PRRT with capecitabine. Of all these modalities, that has the best response rate.
So Dr. Nikhil, few more questions, I think, and then we can summarize.
We don't have much questions. I mean, if somebody wants to ask a question, can unmute themselves and can ask.
I think this patient who Dr. Sandeep presented has been treated excellently. I think the point to make is most of our patients actually end up having most of the treatments that we talked about. And so I think, excellent treatment for this patient.
I think it's patient should get each and every treatment which is available if they are eligible for to improve their survival outcomes.
Yeah. One thing is doing a biopsy, whether we should consider doing a biopsy at some point, mainly like you said, to do MSI and to do TMB, because again, TMB is also a blanket approval. And some patients I would send for, even if it's a 50 gene panel in one patient, not my patient, but I saw it as a part of a TMC thing. So I had an NTRK fusion detected.
Okay.
So was not a neuroendocrine, sorry, it was a GIST. So, but you can find this. It's 1% chance, but I mean, it's great that patient can have access to that. So I think it's worth biopsying at the time of progression and sending it for NGS, whether it's 50 panel or 500 panel, that's different. 50 gene.
Sometimes our intents are good, but the panel issues and logistics issues, like in case we do the biopsy, if there is something like MSI or NTRK fusion gene positive, the panel is not going to give the permission for the treatment.
No, so some of these drugs are available on compassionate use. So larotectinib, and so we're getting so there are 3-4 drugs. Decometinib was in lung, exon 9.
It was in lung, okay.
Yeah, so you can get them on compassionate use for some. I think we have to counsel patients. You're absolutely right. And I've just found a patient who we found a drug which was costing 26 lakhs per cycle. So, either you find nothing or you find something which is so expensive,
right?
That, it's unaffordable literally. So I think that we have to counsel before we send the test. You're absolutely right.
Yeah, Nikhil and Shefali, can we close? We have already
we can, yes, and thank you so much, Dr. Nikhil. Wind up, please.
Just before we wind up, I want to congratulate Dr. Bhawna for the tweet that was tweeted by ASCO to honor her achievements.
Thank you so much.
Absolutely. Absolutely.
Thank you. Thank you so much.
Thank you.
So I would like to thank you everyone for making this very informative. Dr. Bhavna's talk was very brief and very informative, and I actually like that when somebody finishes their talk in time. Generally, we face the issues so far with the time, and Dr. Sandeep actually brought out the practical issues very nicely. So I think that would have been.
Even I finished in time. 40 minutes were given to do. I finished in time.
Correct. Credits to you also.
Thank you. Thank you.
So with that, I think I would conclude, and the next one is in on 20th, and we'll be discussing pancreatic cancer in that. Okay.
Thank you so much. Thank you. I really enjoyed it, and I miss you all.
Thank you.
Bye.
Thank you very much. Thank you.
Thank you, Manoj. Thank you, Rajat.
Thank you, sir. Yeah.
Thank you, Manoj. Thank you, Dr. Rajat.